Get the meeting started. It's a meeting of the Assembly's Chronic Substance Abuse Committee. We'll start with some introductions. If we begin with you, Ms. Gray Jackson.
Elby Gray Jackson.
Pete Peterson.
Bill Evans.
I'm Al Wall. And may I introduce to my staff too? This is Sherry Hinshaw on the end and Joan Houlihan.
Next week, we tend to go around and introduce everybody in this committee since we have a lot of repeat offenders here. So
I'm Christopher Constant. I'm with Fairview Community Council and Business Association. Maybe Aquila today, but probably not.
Hi, Tracy Runyon Trailer from ANTHC.
Good afternoon, Shauna Hanna, ANTHC.
I'm Colleen Ackerman, Program Manager, Carlick Manor.
Duncan Brooks, Program Manager, Road Home.
Michelle Baker, Acting Vice President, Behavioral Health, South Central Foundation.
Elaine Dahlgren, Volunteer from America, Alaska, CEO.
Jerry Jenkins, Anchorage Community Health Services.
Allison Kerr, Covenant House.
Warren Jones, First Covenant Church, AFAC.
Janet Jones, First Covenant Church, AFAC.
I'm Kathy McHugh. I'm an emergency physician at Alaska Native Medical Center.
Deanna Thomas, Alaska Native Medical Center.
who's in the back?
Zach Wright, he's Alaska Public Media.
I'm a student for U.S. government.
Steve Ashman, Anchorage Department of Health and Human Services.
Sharing Reporter, Shelby Sherman, Amanda Moser, Clerk's Office. And before we get underway, the documents are on this right table over here, and there's blueberry muffins in the back from John Lau. Drop them off for everybody.
Let's help yourselves to the muffins. Okay, our first presenter today is Mr. Wall, and we're going to discuss some of the ways in which the state and Anchorage can work together to create some synergies in solving the problems we've been dealing with. It's all yours, Mr. Wall.
All right, thank you. I really appreciate the invitation and the opportunity to be here. It is a conversation I've long wanted to have with the city, and there are a number of different projects going on right now, both in the state and the city, with different providers that all kind of point in the same direction. So I was just talked to Mr. Evans a minute ago, and I think it would be, we would get a lot more mileage and a lot more impact if we work collaboratively on those efforts. And so I'm excited about some of the projects that are out there. I did want to give you a little bit of an overview of the Division of Behavioral Health for the state of Alaska. You're talking about chronic homeless and chronic inebriate issues. There are many different problems that play into that. Some of that is just strictly housing. Some of that is mental health. Some of that is substance abuse treatment. Some of that has to do with continuity of care across the state and the lack thereof. So in particular, I'll just mention in a lot of the outlying areas, there's very little care for behavioral health. And so individuals are coming to Anchorage, of course, to get treatment, and they end up staying here. And so the cycle and the growth of that population is staggering at this point. So what you see up there is something that the division calls the lollipop chart, because it looks vaguely like lollipops if you look at it that way. And it is the continuum of care for the division in dollars and cents and overview of people. So how the continuum of care works, if you think about it on a continuum, at the far left you have those services which are prevention-based, generally cost less per individual to give, and they are difficult to quantify in the long run because you don't actually know how much you saved by doing preventative work, but we do know that we do save money and we save lives by doing preventative work. Prevention comes in a variety of shapes and sizes, anything from suicide prevention to fetal alcohol syndrome. All of those things are preventable, and we put some funding into that. I'll just describe a little bit of the way this is set up. So I don't have a pointer with me. In prevention, we don't do the average cost per individual that we see, because a lot of preventative work is something along the lines of a media release through television or something that's in print, and a lot of people see that, or it happens in a school setting where there's multiple people in the room at the same time. So, thank you. Aha! So you see, this is an average cost per contact. for prevention. This is in budget dollars, so it's just a point with a 1 digit after that. That means it's in millions. So this is $10,963,300 total that we put into prevention. This is the number of contacts that we have, and of course, you see that that's more than the number of people in the state. We just average how many times they could possibly see the same message or different messages for prevention. And you'll see the breakdown here, and I'm going to go in a little bit into detail on this one so you can see how the rest of it works. But the breakdown, GF means general fund, so that is funding that comes straight out of the state coffers. And then in this case, there's some federal match. 32.1% of it is federal matching through our block grant SPIF-SIG. And then there is other funding here that comes from different sources. Some of that is also state funding that comes in through interagency receipts. So the bulk of state funding of this $10.9 or $11 million really is around 60% for prevention. So I took a minute there to show you what the rest of this is going to look like. The next step up is domestic violence. And I'll let you just look at that piece there. The next step up is the Alcohol Safety Action Program, the therapeutic courts with the state of Alaska. We have therapeutic courts here in Anchorage, out in Bethel, in Juneau. We've stood one up in Fairbanks, and we're standing one up on Kenai. Those are alternative programs that are alternative to jail time for substance abuse charges against an individual. Basically, they submit to daily breathalyzer tests and mentoring and constant accountability, and the program has wonderful results. It's also paired up with the 24/7 program. There is a very high degree of success, and I think that you all are pretty aware of the ASAP program in the courts. The bulk of our work for behavioral health is right here in the middle, and by the bulk I mean the heavy lift is right here. It generally falls into two areas. One is serious mental illness, and the other one is behavioral rehabilitative services, which is generally substance abuse. This is the population that is highest at risk for homelessness and chronic issues along those of that nature. When you look at a homeless population, typically from a clinical viewpoint, you divide that up into a couple of different groups. So you'll have people who are homeless simply because they have no job and they have no place to stay. That's a pretty easy one to point out. You have people who are homeless because they have a serious substance abuse problem and they get caught in that cycle and they stay there. And then you have people who are homeless that have a serious mental illness of some sort and may or may not have a substance abuse problem along with that. So the bulk of the heavy lift for treatment of these individuals is right here. The community behavioral health centers, our psychologists which do evaluations in the state, and then behavioral rehabilitative services, of which there's a number of you in the room, so I don't have to explain. This is funded through two different funding sources. One is Medicaid and one is grant services. And I don't mean to insult anybody, but I'm just going to do a real high-level overview. So for those of you who don't know, there are things that can be reimbursed by Medicaid that are medically necessary. Medically necessary interventions or treatment can be reimbursed by Medicaid if the individual is eligible. A lot of the population that we're talking about are adults that fall in that gap who are not eligible for Medicaid for just that reason. And therefore, their services are provided almost entirely under grants. Grants provide a broader spectrum of opportunity, and they can provide client support services, and they can provide supported housing, supported employment, all kinds of things that may or may not be medically necessary, but can be paid for. We have a very limited amount of funds in grants, obviously, and I'll get to the other handout in just a second. But if you look at the outlay, there's $188 million total for community behavioral health centers. The unduplicated count of the individuals that they served in the state of Alaska was 28,380. And I don't have the math up there. Oh, I do. It's right there. 6,629 average cost per client. For substance abuse treatment, this is both residential care for child and youth, residential treatment, and outpatient. There is $6,160,500 there. and you can see 662 people served. I don't think this is the entire picture. There is a great deal of treatment that is occurring for individuals there. As I saw Rosalie come in. There's a lot more people being served, but these are the people that we count because they're in our system and they have to do with our funding. And I will quickly go up the scale here just a little bit so you get the fuller picture. Designated evaluation and treatment stabilization. These are funds that are spent on individuals who have a psychiatric crisis and need to be transported to a place for evaluation. This does have bearing on the homeless issue here in Anchorage because, as I said before, a number of people are coming in from the bush and they come in for evaluation and treatment. When they get here, they get evaluated, they get treated, and they get released. Many of them do not return to where they came from. Much of that's because there's not any care where they came from. So they're released, we'll just give you an example. If they're released from a place like API, which is in our organization as well, they have 3 days medication and they're released with a plan of care. And it's up to them to get to their treatment and get hooked up with their next medication so that they don't decomp. And in many cases they do, and they end up getting caught in the cycle again. So that's DET. The next one up is actually acute psychiatric care, API. This is a hospital that is run by the state, and it is the kind of the anchor of the acute system. So in the continuity of care and the continuum, I always think about API being the safety net on this end. When all else fails, this is where people go. When you come to think of it, it's 80 beds. It's an 80-bed facility. And there's not a whole lot of availability for that level of care in the state of Alaska. This is the only inpatient acute psychiatric hospital in the state that accepts everybody regardless of age and ability to pay. So it is very limited in its capacity to help. It's basically there for stabilization and restorative treatment, and it does work a great deal with the courts. And you'll see people in the homeless and chronic inebriate category. If they have a serious mental illness, for example, they could end up committing some crime. Breaking and entering is a very typical one for a seriously mental ill person. They just will walk into someone's house because they feel like they need to be in a house, and then they'll be charged with a crime and they'll be, sent to court. And the judge will say, well, this person is not behaving like they're competent to stand trial, so they'll be sent for evaluation at API. Typically, if they're found incompetent to be tried, they will stay there and have restorative treatment occur at that location. Then again, they end up being more of the problem when they're released, because then they're released into the same problem that I talked about earlier, where they have very little continuity of care, limited medication, and they typically do decomp at some point. The next group here is, again, acute psych. There is like North Star here in town, which does care for children who have acute need. So that's group. And then on the far end here is residential psychiatric treatment centers. Much of this occurs out of state. There are some in state as well. And this is typically long-term care for people who have complex need and may or may not have crossover issues with some developmental disability and along with their serious mental illness. I want to take just a moment and point out to the top, this is all the Medicaid. The chart on the top left is Medicaid. So you'll see that it's broke out there by prevention, early intervention service, Medicaid here. There's our grant dollars, and there's the total cost. So there are no Medicaid payments for prevention, early intervention, because Medicaid, again, has to be medically necessary. This is our total outlay of cash for treatment for behavioral health under Medicaid in that year, fiscal year 2014. So $166.6 million. In addition to that, these are our grant dollars for that year as well. So this is the prevention number, this is treatment and recovery number, and this is the total. And then you have the total cost. On the far end, you see the unduplicated count of patients across types of service. I don't know.
They're on the desktop if you want to pull up the other ones.
Are they? I'm going to go to the map. I see. I'll go to the maps, and I apologize that, in particular, this one, the one with the reds on it, the numbers on it are very small, I apologize, but we had to cram them all into one place. I like these maps because they show geographical area and the expenditure amount that we have for them. I'm going to do the one with less numbers on it to start out with. It says DBH grant awards by service area and grant type. And it has just blue and yellow on it. It is this map right here. Doesn't want to cooperate. And they just sent me the information on Medicaid. Okay. So these are just grants, and you'll see in the left-hand column there's treatment and recovery. In the middle column, which is yellow, there's prevention and intervention. And on the far column, there's a total. And as you can see, if we're going to look specifically at Anchorage, it's the biggest pie chart, obviously, the most population, and it's the top one on the chart. Anchorage received in 2015 $22.6 million for treatment and recovery and $2.3 million for prevention and intervention. And you can see how that compares with other regions in the state on that chart. We're having technical difficulties, so I'll just walk you through it. And then if you go to the next one, which is this, it's a little bit more complex, has more numbers on it, and they're smaller, and it has red colors in it. And I have to take my glasses off. Again, Anchorage is at the very top because it's in alphabetical order. There's a little key at the bottom that tells you what program type we're talking about. This is 2015 Behavioral Health Treatment and Recovery Grant Awards by Service Area and Program Type. So the key says Psychiatric Emergency Services is one type of grant, Severe Emotional Disturbance for Youth is another type of grant, and so on and so forth. I think the ones that you might most be interested in, perhaps, are Psychiatric Emergency Services, Substance Abuse, Residential and Outpatient, Detox, Opioid Treatment, and Support Services, and we'll speak to that in just a minute. But if you look at the actual chart, it says that Anchorage received $1.2 million in emergency services, psych emergency services, $2.8 in serious emotional disturbance, $5.8 in serious mental illness, and so on and so forth, across to the total, which is $23.6. Let's see if it matches the other one. Aha! It matches. Outstanding. So, I wanted to give you that information so you could have kind of the background of it, and then kind of talk to you about some of the programs that are currently on the street. I brought two of my staff members, our subject matter experts, which know a lot more about specific issues than I do. Sherry Hinshaw is currently the Office of Integrated Housing Manager, and she handles all the support services, type of services that we give. So supported housing, supported employment, those types of things. And then Joan Houlihan next to her is our subject matter expert on substance abuse treatment and recovery. So I brought them so that they can answer questions so you get the right answer. Because I'll make it up. Some of the things I'd like to highlight, programs that are going on. Again, you might be aware of these. Last legislative session, at the close of the session, the legislature granted the state, after some arm wrestling, thank you, Mr. Constant, the $4 million for chronic inebriate and homeless project, which actually was granted through the capital side of the budget, which is a little different than our operating side. It's time delimited. Oh, there we are. Thank you. So we have basically 3 years of that funding, and I see it as a tremendous opportunity to start something and build sustainability into it. We broke that into two types of grants for the two populations that I described earlier. So typically, homeless population, chronic inebriates can be divided into those that have serious mental illness and need that treatment in addition to substance abuse treatment. in people who don't have a serious mental illness and therefore just need their chronic inebriate problem treated. And so we broke the grant money into two different programs: the intensive case management program, which is designed to focus on the chronic inebriate program, the individual with substance abuse problems, and then, I'm sorry, my brain's getting fuzzy, I've been talking a lot. And then we broke it into the ACT team, which stands for Assertive Community Treatment, which focuses on individuals who, in addition to their substance abuse problem, have at the core serious mental illness and need that treated as well. The other program that's out there that dovetails into this is the reentry program that currently has a great deal of momentum in the state. So at the same time they passed the $4 million for treatment, they also passed Senate Bill 64, which was basically an anti-recidivism bill, and focuses on individuals that are coming out of the jails and providing them continuity of care and treatment for their issues, supported employment, and things of that nature to try to get them from cycling back through, to stop them from cycling back through the legal system. The reason why that's important is because there's a great number of that population that come out, and there are a couple of different, I know Jeff Jesse, if he was here, he would say 80%. There's a couple of different sets of numbers about how many people come out of jail that have a substance abuse problem when they come back into regular civilian life. And whether or not they're currently acting on that substance abuse program, it's there and it needs to be addressed. And so hooking them up with treatment is extremely important. It's absolutely critical. And of course, we also have that same population demographic, which these are typically adults of the age category that are not eligible for Medicaid. So then you have the question of who's the payer source for this treatment of people that are coming out. So if you have basically 350 individuals that are dumped out of the jails on a monthly basis in Anchorage, then you have 80% of that population that needs continuity of care. I mean, I'm just following the numbers. At some point, you're going to reach critical mass of what you can treat and where your funding is. And at this point, we have reached critical mass. Our treatment dollars have not gone up, and we needed infusion to do that. One of the things that I would like to talk to the city, the municipality about is that infusion could look something like the state and the city working together to kind of double down our money, so to speak, and see if we can't make impact. I think the time right now is a very critical time in the state. It's a very critical time in the city, and we have the opportunity right now to turn it around. I really think that way. We just got done with the annual schoolhouse for addictions last month. It ended in May, and I did the introduction speech for that. And when I got up there, I talked about the good things that we had been doing, because I just got the SAMHSA report on the state of Alaska, and they report historical information over time on all the major categories of substance abuse. And to my great delight, we have gone down in all critical areas across the board. Every single one in FY15 went down. So binge drinking and all of these issues that you look at individually all went down, statistically speaking. And then there's, at the same time I had just attended the therapeutic courts graduation, and there was a number of people that graduated. It was a great, positive message that they gave. There was a lot of testimony of people there, and the recidivism rate among those people is very, very, very low. And so that's a good impact. And so I talked to the annual schoolhouse people, who are all substance abuse providers, about how well they were doing, and we are making an impact, and it's good. But at the same time, I told them that Sunday night, I walked from the Marriott where I was staying down to Beans Cafe by way of 4th Avenue at 11:30. And I do that on purpose. I do that occasionally in the city because it's important to remind myself, and it's important to remind my staff, that we're working on a very critical issue. This is life and death. These are people, and they're very real. They're not statistics. They don't need to be relegated to numbers and stuff that I talk about on the screen all the time. They have an impact on every single person in this city, whether or not we know that. On my one-way trip down to Beans Cafe, I counted 96 people from the Marriott down to Beans Cafe that were either horizontal or close to it. And so, well, at the annual schoolhouse, I said, you know, while we're doing very well, and I applaud you for your efforts, we've got a lot of work to do. And I would like to just offer my division's support and collaboration to the municipality on the services that they're looking at providing, the potential they have for impact as well, and anything I can do to assist, I will. Unless there's any questions, that's what I have to say.
Sure, any questions? Actually, I don't have any questions from the audience. I don't have any questions. I'm certainly heartened to hear your perspective and your attitudes. It's certainly, we're looking for the same thing, to collaborate on this problem, which is not a city problem, it's not a state problem, but it's a problem for all of us. So, and I think there are certainly areas that working together we can do better on. So I look forward to creating that better partnership. So there are a couple questions, and we'll start with Ms. Gray Jackson.
Thank you, Mr. Chairman. I'm sorry I'm late, and I don't have a question, but I listened to everything you said, obviously, and I really appreciate your presentation. And I think it's a really great idea for the state to work with the municipality. And it's especially great now that we have an incoming new mayor who may be more willing, not to criticize the current mayor by no means, but may be more willing to work with the state on in any way that we can. And I think what's really, really important is that right away, we need to identify what services the community provides and what services the state provides, and figure out really quickly how we're going to work together and what's needed to do that. I think that's really, it's nice to talk about it, but we need to get moving. Again, thank you for your presentation. Thank you, Mr. Chairman.
Thank you. Mr. Peterson.
Thank you, Mr. Chairman. And I'm glad you walked us through why more people from the bush keep ending up here in Anchorage. The fact that they were actually sent here for treatment, and then once they're released, they have nowhere to go, answers the question of how come we're getting more people treated and we still have an increasing number of people. At least we have a good idea where most of them are coming from, and I think that helps me understand that at least, I think. So, thank you.
I saw a few hands raised. Ms. Nadeau.
Al spoke briefly about our treatment programs. We don't have an outpatient treatment program here in Anchorage that is funded by anybody except us, which means that we're looking at collecting either Medicaid or fees from those people who attend that program, and it's well used. In addition, we just signed a little over $4 million contract with DOC, and I really think DOC needs to be involved in this conversation too. We have 5 community programs. It's one thing to do the programs in the prisons, and we do that. But in addition, we have 5 community programs that DOC funds. And those are people who come out of prison, are usually in the halfway house, but not always. They may have a probation officer who says you have to get in. So we have one in Anchorage, one in Palmer, one in Juneau, new one opening up in Fairbanks, and one in Kenai. Obviously, the Anchorage one is the largest of those, but it doesn't take in nearly all the people coming out of prisons who really need treatment. There's a group, sort of a subset of Al's group, that deals almost exclusively with that population. We happen to be a part of that subset. So I think that's a group that it's important for the city to understand how they relate. And when they're here, why they're in their little house at one of the halfway houses and then wandering across town to treatment. And if they don't finish it, they're going to go back to prison. It's just that simple. And right now, the state doesn't want more bodies in prison.
May I interject real quick? So I have a lot of respect for our providers, all of them. Completely agree with everything that Rosalie just said. I wanted to point out one of the great momentum pieces right now is that reentry program. The governor just set up a reentry council, which was signed not too long ago. I was down here, I guess, 2 weeks ago to do that. And as part of that effort, they actually stole one of my staff. They took Diane Casto, who is the head of the prevention unit and has been working with the state for years and knows a great deal about the systems and people. And she is now the deputy commissioner at DOC and specifically in charge of the reentry program and hooking up individuals that are coming out with treatment and continuity of care and supported housing and things of that nature. So if the Assembly would like, if you'd like some information from DOC's point of view, I highly recommend Diane. She's very good with presentations and she has a lot of knowledge.
Thank you. That's a good idea.
And I'll throw her under the bus if she'd like.
Okay. Allison?
So, and I too, I mean, I appreciate, and I've met with Al on different occasions. I'm with Covenant House. And one of the things, even in talking about, you know, the new grants award and what was happening, so we don't often hear about these grant awards because Covenant House is not funded in any way by any of these programs. But I sit here today and say the greatest thing, we're not going to change the system unless we start with young people. And, you know, I agree that every resource we need to change the situation that some of our adults are experiencing through Brother Francis and Beans Cafe. Every young person I look at, I think of one day could be there, and that we have got to kind of even prioritize and collaborate. And even the two people that were awarded the service grant agreements, even if they came to us and just said, help us understand your outreach, and so anytime we see a young person on the street, we know what to do. Like, we can't do it all. And it just seems that sometimes when times are tough, the most effective way to change things are the ones that are cut first, like prevention. I know that, you know, we had a position funded through domestic violence. Anchorage Community Mental Health was having a full-time person at our facility, probably one of the best things we ever did, and it's cut because it was cut under prevention dollars. So I really do believe that we have to be strong in making sure that we go upstream as well at the same time and really stop the cycle of it, because I can tell you it works, and I can tell you the resiliency in the young person before their soul is just killed. And there's a piece of it that I want to work with anybody that's doing it, and often don't hear of these opportunities. I know that our Covenant House has presented to this council, but even this meeting, you know, Chris was like, are you coming to the meeting? And it's just, if we attended just meetings on everything that affects our kids, I'm not sure when we would get to work with our kids, but I want you to know that we want to partner with anybody, and we want to be at the table, and we want to be at discussions, and we want to be part of the solution, because it's going to take all of us. So
That's shows a tremendous point. The place you stop the cycle is at those transition points. Transition points are individuals coming out of an institution, whether it's API, a hospital, or jail, young people who are transitioning into adulthood, those kids that are coming out of the juvenile justice system, kids that are coming out of the OCS system, you know, those transition points in an individual's lives, that's where you can reach in and stop the cycle. If you wait until they fall into it, you're behind the eight ball.
Are there any more questions or comments? Kenny?
Thank you, Mr. Evans. Thank you, Mr. Wall. Nice to see you and be with you. I heard one of your last comments or offers maybe was a strategic funding planning, a conversation with the city and the state on that. How would that look going forward? Would you call someone, or would they call you? And do you need anything to make that happen as a decision from here, or would you call someone this week about that?
I actually didn't say that, but I really like that terminology. What did you just say? Strategic funding opportunity?
How's that coordination between you and the city?
That's a great idea. So actually, some of that conversation has started at a very low level. Meaning at the start of this meeting, I told Mr. Evans it'd be great if we had to talk about that. And I do see a way forward. I think it needs to happen. And it's not a matter of, it's not a matter of if that conversation happens, it's a matter of when. I can foresee it happening soon.
So someone call you or you'll call someone?
Oh, I will call. Well, I'll probably email. I'm not a big phone guy.
Yeah, and, we are planning to wrap up this committee's work this summer and to have, very specific recommendations for what we think the municipality needs to do. As part of that, in order to get there, we need to coordinate with Director Wall and others to make sure we have those pieces where we can build linkages with the state. So that will be happening over the next several weeks, and if he doesn't email, I will, but we'll make sure that does get taken care of. Mr. Krajak?
Thank you, Mr. Chairman. Mr. Wall, I just need to make a little comment in relationship to what you just said about the fact that you have talked to somebody at a very low level. Not that I'm Mr. Evans' bodyguard by no means, but this is pretty much a high level because the next level is the mayor. Thank you, Mr. Chairman.
Mr. Evans referred to you as low level?
I thought it was apt, but...
Well, in my comment, just looking at the chart, the further to the right you get on the chart,
right,
the more expensive per individual, per client it gets. So we're much better off if we can catch them over in the far left side of the chart, if that's possible.
So that's part of my normal presentation, is we call that keeping them out of the deep end of the pool. So deep end of the pool is on the right-hand side, and if we can catch people at prevention and not so they don't even get into a problem, that's the best opportunity. But if we can keep them at the lowest level of cost possible and intervene as early as possible, then we do a lot more good than waiting until it's at an acute stage.
If I could just add one thing, Al, if you don't mind. So I think many of you know because you've been involved, but DVH and the Alaska Mental Health Trust Authority have been conducting stakeholder input sessions for a statewide strategic plan on supportive housing. And the purpose of that plan is for DHSS and its partners to come up with a list of recommendations for how to streamline funding or service opportunities in order to create supportive housing for trust beneficiaries. So really it's a cross-disability approach to integrated housing and service opportunities. And that process is actually wrapping up in the next month with a strategic plan to be released the end of July, and so that is something that could be released to this group for review because there might be some recommendations in there. That plan is also being aligned with the Governor's Council 10-year plan on homelessness, and that will most likely make up the majority of their supportive housing section, as well as the Mental Health Trust Authority, their housing and long-term support services will begin to align with that plan. So it's a way for DHSS and AHFC and working with the Muni to put forward recommendations about how funding could be aligned more closely to develop increased supportive housing opportunities.
Excellent.
That's a great project that's underway, and it will have implications for the future immediately. The other thing that she was mentioning, though, is it really is, it looks also at where the gaps in service are, where the gaps in housing are, where the gaps in supported services are. And earlier, Ms. Gray Jackson was saying we need to identify the types of services that the city provides and the types of services that the state provides, and I completely agree with that. We also need to identify where our gaps in service are, what we don't provide. And the THC is one of those things that's going to help us do that.
Final comment, Ms. Nader?
The housing issue, I think, is a terribly important issue. Our people coming out of treatment are likely to fall if that housing support is not there. However, housing alone is not enough. There've got to be supporting services. You folks had a guy from, I think it was Minneapolis or Minnesota, in any case, who has a big assisted living, supported housing kind of program there. I spent some time talking to him after he did his presentation on housing, and he told me the housing wouldn't work if they didn't have the supporting housing or the supporting services around it. Things like substance use treatment, things like mental health services. That housing alone is not the answer. but it has to have the supporting services located in close proximity.
If you have not had an opportunity to look at the material that came out of that Homeless Coalition meeting, I highly recommend it. We'll get that to you. There's a great deal of excellent material that came out, presentations like that one. Really good information.
And I know next to nothing, but I do know, based on everything we've heard through this committee thus far, that nothing is the sole answer for this problem. It requires all those different pieces, and that message has been drilled home to this group, you can rest assured. Okay, with that, Director Wall, we thank you very much for your comments, and we're greatly encouraged by these opportunities.
Thank you.
We're going to move on to our next presenter now. And I know Tracy is here, and also Ms. Hegna is here also, right? I don't know if ever one of you wants to go forth, please do. Okay, perfect. More the merrier. During this transition, you can get your blueberry muffins in the back.
Let's hope we start.
Good afternoon. I'm Tracy Runyon Trailer. I'm the Associate Nurse Executive at the Alaska Region Medical Center. I have a few colleagues from ANTHC along with me who are subject matter experts and are available to answer any questions.
Hi, hello. My name is Shauna Hegna. I'm the Chief Administrative Officer for the Alaska Native Tribal Health Consortium.
I'm Deanna Thomas, and I'm a social worker at Alaska Native Medical Center for 16 years.
And I'm Kathy McHugh. I'm an emergency physician at ANMC.
So, committee members and staff, on behalf of the Alaska Native Tribal Health Consortium, thank you for the opportunity to discuss the impact of chronic homeless inebriates on our emergency department. Before I describe these impacts and potential opportunities to address them, I'll give you a brief overview of ANTHC. ANTHC is a nonprofit tribal health organization. The consortium is the largest, most comprehensive tribal health organization in the United States and Alaska's second largest health employer, with more than 2,400 employees offering an array of health services to people across our state. ANTHC's vision is that Alaska Natives are the healthiest people in the world. To reach that vision, we offer statewide services in tertiary and specialty medical care, water and sanitation, community and health research, and information technology. In Anchorage, we are most well known for co-managing the Alaska Native Medical Center. ANMC is a 150-bed hospital providing a full range of medical specialties, primary care services, and labs. The hospital also works in close partnership with Alaska's rural health facilities to support a broad range of healthcare and related services. ANMC was Alaska's first hospital to receive Level 2 trauma designation in 1999, providing the highest level of trauma care possible to our patients. ANMC serves as a referral center for every tribal health facility in the state. In 2003, ANMC became the first hospital in Alaska to receive Magnet designation for nursing excellence. Today, we remain Alaska's only Magnet designated hospital. Less than 7% of American hospitals achieve Magnet designation, a recognition of nursing excellence by the American Nurses Credentialing Center. Alcoholism and homelessness are issues that impact the entire community and require a community solution. At the Alaska Native Medical Center, alcohol-related visits make up 11% of our emergency department visits annually. That's almost 3 times the national average. Out of the individuals who have alcohol-related visits to our emergency department, 47 of them are considered high utilizers. These individuals represent only 4% of our patients with alcohol-related visits, but they account for 20% of those alcohol visits. This means that these patients use the emergency department services at a disproportionately high rate. High utilizer patients are typically homeless or have fluid living situations, such as living with friends or family members, and are often chronic inebriates. This population was frequently transported by EMS because they were too intoxicated for the Anchorage Safety Patrol, had a medical complaint such as abdominal or chest pain, or they or a bystander requested EMS response. The average length of time in the emergency room for high utilizer patients was around 3 hours. Of note, high utilizer patients do not just access A&MC services, but are seen at other local hospitals, both in the emergency department and as inpatients. Multiple alcohol-related visits are associated with increased healthcare costs for the use of EMS services, emergency room visits, and inpatient care. For example, one high utilizer patient visited the A&MC emergency department more than 80 times in 3 years, accruing charges of more than $300,000 for care. These charges do not include the cost for EMS transport, the Anchorage Safety Patrol, or any other non-related A&MC expenses. Many high utilizers visit the emergency department when their care would be better served in a less acute environment. If these patients saw a primary care provider regularly, their emergency department visits would likely decrease, saving A&MC, EMS, and other community program costs. Several local services, including the Anchorage Safety Patrol and Carlick Manor, have been instrumental in caring for our chronic inebriate patients. On behalf of ANTHC, we thank the staff and leadership at ASP and Carlick Manor. Notably, we have seen a marked improvement in the ASP's responsiveness in the last year. We also have seen a dramatic decrease in the emergency department visits as soon as individuals are housed at Carlick Manor. Both organizations display respectful and courteous behavior towards our patients and are timely and responsive to requests for assistance. Chronic inebriates impact our ability to care for patients who truly require emergency services. We often find that once the medical issue has been addressed by the emergency department staff, that we are unable to release the homeless inebriate until they are sober, which increases their length of stay. After their medical issue has been treated, staff must still provide care and monitoring to provide for the patient's safety. This means that critical staff resources are redirected from other patients who require emergency services. We have been severely limited on the amount and type of support we can provide to chronic homeless inebriate patients because of the limited availability and funding for community resources. Once we have treated the patient's medical issue, we work in partnership with South Central Foundation to conduct behavioral urgent response team consults. During this consult, we ask the patient if they want to be referred to a substance abuse program. However, if the patient chooses treatment, we are unable to meet the request because emergency substance and alcohol treatment is currently unavailable. This means that once we resolve the medical issue, we have no choice but to discharge our patients back onto the street until a slot opens up in a substance abuse treatment center. This can take weeks or even months. Once our patients have been discharged, we have missed the window of opportunity to engage them in community support services. If a patient's medical condition requires ongoing supervision but does not require an inpatient level of care, then we often utilize an inpatient bed because we have no place to safely discharge them. In these cases, patients are placed in acute care beds for non-acute medical needs. Homeless chronic inebriates typically have much longer lengths of stay. The average inpatient hospital stay is 3 to 5 days. Homeless chronic inebriates generally stay much longer because they have conditions that require supervision. In the last year, ANMC has gone on divert on multiple occasions because our beds were simply full. This means when there truly is an emergency in the community, we cannot care for those individuals because we have no rooms available. While these issues may seem insurmountable, there are success stories at other communities that have done it right. Utah has a 10-year plan to end both chronic and veteran homelessness by the end of 2015. Chronic homelessness has declined 72% since 2005, and chronic homelessness amongst veterans has reached an effective 0. Declines are primarily due to the provision of permanent supportive housing for targeted individuals using a housing first approach. As you know, housing first means providing housing first rather than requiring sobriety or other steps to be taken prior to housing. This method has proven to be highly effective and cost efficient. Utah is one of the many places where housing first has proven to be successful. We believe that through collaboration, we could dramatically reduce the number of chronic homeless immigrants in Anchorage. We recommend additional support services for this population, including more housing first options, primary care services in the downtown area with a stable schedule, and behavioral health services and support for alcohol-related issues. Again, thank you for the opportunity to present information about an issue that impacts our entire community. We look forward to partnering together for a community solution. Again, I do have a panel of subject matter experts available if there are any questions.
Are there any questions for the panel?
No, thank you, Mr. Chairman.
Mr. Peterson?
Thank you, Mr. Chairman. So you said you have 150 beds, and that's total, and are some of those designated more for like chronic inebriates, or they're available for any member of the population that comes in, or?
It's 150 beds that includes pediatrics, ICU, mother-baby, L&D, and regular adult inpatient beds. None of them are specifically designated for chronic or inebriated homeless patients.
And if I could follow up, typically on an average day, if there is such a thing, how many of those beds are you using to detox individuals?
I don't know if I have specific numbers for detoxing patients. I can say that our non-acute beds, meaning those patients that don't meet the inpatient level of care, can range anywhere from 10 to 20 per day.
All right, thank you.
Mr. Peterson, you have a question?
I want to thank you guys for what you're doing. I do outreach on the street and I've been to your emergency facility a number of times, Dr. Paris and others who have helped, and felt the yearning that they have to help, but the inability sometimes, and going through your urgent down the hall and the primary care, and how much the teams that you guys build. It's an amazing effort what you guys are doing, and I'm sorry about the limited resources. I did hear your offer about collaboration, and obviously we've heard that the state and the city is going to be collaborating here before long. Who would be the best one on this that the city would collaborate with to find that kind of solution like you described in Utah or otherwise in your facility?
You're welcome to contact me. I'll give you my card after we're done.
That'd be wonderful. Thank you very much for what you're doing. Sorry for the burden that we place upon you.
Peterson's forging all the links, making sure everybody communicates and gets together.
It's
Good
coming
job.
together. It's great.
Yes. That's what has to be done. Good work. Any other questions or comments? Yes, ma'am.
I'm Colleen Ackerman, the program manager of Carlick Manor, and I don't have any questions. I just actually want to thank all of you for the work that you do with our tenants and our staff. We really can't thank you enough. I mean, I know we try to prevent them from going to the emergency room. Occasionally that can't happen. But all of you have worked really hard in getting them in as quickly as possible to primary care providers, rescheduling appointments, helping us get different medications, different providers, whatever, and you've been great. And Anchorage Community Mental Health as well, we really wouldn't be able to serve our tenants as effectively without the services that they provide in the treatment agency. So thank you for coming and for the work that you do.
One of the things that they talked about were the need for services and supportive services. I don't know that the city knows this, but the state, when I began working at Aquila House, which was 1992, the state was funding 40 beds. Now it funds 18. And we're in the same facility.
That statistic has been bandied about a bit. I'm aware of that.
And it isn't just me, that's happening everywhere.
Question for you, I mean, you mentioned the impact on, the residents of Carlick Manor having a decrease in the need for your services. Since the opening of Carlick Manor, has there been any decrease in your services, or has it just been replaced by non-residents of Carlick Manor? See nods, I guess.
When Carlick Manor first started, it was amazing. There were actually entire days I could be in the ER and not see any chronic inebriates at all. And of course, with time, it's been, 2-3 years now?
Over 3 years.
3 years now.
3.5 years.
Unfortunately, people have kind of moved in and are, kind of moved up, and now we have a new generation, if you will, of kind of chronic frequent utilizers of Anchor Safety Patrol and us, and occupying a lot of AFD and APD's time. And so we're starting to get a whole new crop of them, and they are there very frequently. And yeah, I just keep waiting to hear about another housing first, because it really, it's amazing what you guys do. And you bring people in appropriately, you pick them up, you take good care of them, and we're seeing some of these people that I saw for years, 10 years, come back and they're sober and they look great, and you're making a huge change. It really, really helps us take care of our patients better, all the other emergency patients.
Elsa?
Yeah, it's a praise day, because I too have had some wonderful experiences with the organization and some of our kids, and just the care and the respect that you give the people that come there to receive services, and I just want to thank you. One of the challenges that we have is just a very limited number of detox beds, like we're all saying, and the detox component of it really does require a medical piece. And I'm just wondering if you've ever thought of, if we were able to, of course, perfect world, find the resources to do it, has ANHC ever thought of a small amount of beds being dedicated to medical detox? You have the physicians there, and you could probably do it cheaper than if one of us was to build a place in order to do it. And I'm just wondering, with your partnerships, and I know you have the resources of South Central Foundation as a partner too in behavioral health, is that ever an option, or is it just such a limited number of beds that, the improbability doesn't exist?
That's a really interesting idea and intriguing for sure. I think that at the current moment, we're so challenged with capacity, but I think that would be an interesting discussion.
So if I could just add to that, the Alaska Native Medical Center has grown 300% since 1999. We are literally busting at the seams. And earlier in our presentation, we talked about going on divert, which means that we are, every bed in our hospital is filled, all 150, and we have no place to put patients. And as a level 2 trauma center, that impacts the services of not only our Native families, but our non-Native families. So if somebody has a four-wheeler accident, somewhere in Alaska, no matter if they're Native or non-Native, they come and they see us. And when we don't have a bed for that person, we have to send them to another facility. And so thankfully, Providence has joined us as a level 2 trauma designation recently, so we're delighted to have them at the helm with us. But that has a severe impact. So at this point, Allison, for us to then plan to look at detox beds, we're just trying to be able to see trauma patients so that, if somebody has a stroke, they have a place to be seen. And so when we're struggling with being at capacity, looking at a detox is not somewhere that we're looking right now. That doesn't mean it couldn't be a conversation or something we could explore in the future, but just to frame that a little bit for you so you have an understanding of where we're at as a facility. We are doing extensive expansion. Anytime you go by the Alaska Native Health Campus, you can see that we have construction in the works, but we simply have grown exponentially, and the number of patients we see is astronomical.
I think it's one of those things that I finally found myself as like an old timer, working at Covenant House like 18 years. And I think in order for us to change this, we're really going to have to think outside of our box. And I know that we even get into this little box of how we do and how we serve. And I've often thought, in our wellness center, we have 2 beds. Not that I want them to necessarily be medical detox, but if we had a partnership with, you may not have the capacity building-wise, but maybe if you have a doctor who could come over and help our staff with it, what we're finding is many of the young people don't need an extensive part. Ours, we just need to know one way or the other. And so they end up in an emergency room for the doctor to tell them, you're not going to die, you're going to be incredibly uncomfortable for 4 days. You know, they could probably stay with us. And we just don't have the medical expertise. And so sometimes if we think about this collaboration in a more mobile way, then maybe there are others that have space. You know, I have a scared staff that doesn't want anybody to die inside the program, and I get that, and I want them to get the information that the teams could come together and they could help educate our staffs on ways to partner in that. So, you know, whether you have the physical space, maybe sometimes think about, even if you came over and just routinely talked to the team, we might be making some headway, at least for a couple of kids that I know end up with you that could have stayed with us.
One comment to that. Remember, every single Alaska Native patient is assigned a primary care provider. We have a medical home for every single patient, so you may want to start by talking with their primary provider and who can prescribe something to do outpatient that you guys could monitor almost like as a parent would. So that's an idea. And then also getting back to just our capacity to care for patients. I'm also on the mayor's EMS advisory board, and recently we reviewed numbers for diversion, and ambulance diversion is basically when your ER is too busy, too full, it's not safe for you to take another patient. Maybe you're holding a whole bunch of ICU beds, patients downstairs because there's no beds upstairs, and you're at capacity, you can't safely take another one. And just to kind of let you guys know how ANMC is doing, last year we had 24 days of ambulance, if you add up all of the hours where we had to go on diversion, you add them all up, 24 days of the year, that number of hours, that's how much we were on diversion because we couldn't possibly fit another body safely in our hospital. And the next hospital was about 3 or 4 days. I mean, we are totally busting at the seams, and it's hard, and we definitely want to work together with everyone on this, but we're very, very busy and trying to do the best we can to take care of as many patients as we can safely.
Ms. Gray Jackson, any question?
Thank you, Mr. Chairman. Thank you first for the presentation. It was very insightful, and I really appreciate it. But I thought I heard you say, and I don't remember your name, but anyway, that the Native Hospital serves non-natives?
We do for trauma, level 2 trauma situations. So we may have, for instance, a non-native individual who has a head trauma or a heart attack, and they would be able to come into our facility to be seen in instances like that. Now recently, for a long time, we were the only level 2 designated trauma center in the entire state. So we saw all non-native level 2 trauma patients. But now Providence has joined us in that designation, I believe in the last calendar year. And so now they're available as well to see non-native patients who have trauma situations.
I just have one dumb politician question. Given the experience with the opening of Carlick Manor and the decrease you saw initially with their population being housed, and if we were to create another Carlick Manor, what other steps would you say we need to take in order not to be in the same place 3 years afterwards, where we've just now have a new population coming in, taking the place of the ones we've housed in Carlick Manor too? If you have, and I imagine, you mentioned substance abuse treatment availability as one. Is there anything else that you would recommend to keep that cycle or that pipeline from just continuing to fill up?
Another one of the things we mentioned was having primary care available close to where they already receive a lot of services, and something that has a very stable schedule. I think that there are organizations that are currently providing some level of primary care. However, the schedule is not stable, and so patients don't know when they can access those services all the time. That was one of the things that we thought could help treat some of the medical issues earlier on.
Chris has an idea.
Just a note to that, in a lot of the discussions we've had, there's been discussions of adding some form of a medical triage at the shelter, at the food kitchen, and that as a regular basis, a place where people who are down there know they can go to get basic medical attention and provide triage to know, well, does this person need to go to the medical center, or do they really just need to have a Band-Aid, so that you don't need an ambulance at every call and then tie up a whole EMS. So that is a discussion that's very important.
Did they lose their nurse practitioner that used to go to Brother Francis? They used to have the care clinic down there. Did anybody know if that's?
Still in the
did they-
very
They still do.
consistent hours.
Yeah.
So no one knows to count on it, so if you have anything, you just call an ambulance and come to the hospital. And then we see you.
See no other questions? We appreciate your time coming here, appreciate the perspective and getting to know more about how this issue is impacting your institution. Appreciate it very much. Thank you. And we had some discussions about detox. Ms. Lake? We do have we added on another presenter. We've heard from Cliff Linton at Tribal Council previously, but we also have Ms. Rebecca Ling back here today to talk about some more concrete issues surrounding detox, and the potential costs and the potential opportunities for that. So, Ms. Ling, take it away.
Yes. So I'm Rebecca Ling. I'm the Director of the Recovery Services at Cook Inlet Tribal Council. And we were asked to come back to clarify a few questions. We were asked how many folks were on our wait list currently for detox services. And as of yesterday, we had 30 individuals actively calling for a bed. So that means they've called that day. There are many other folks that, call inconsistently, but currently 30 individuals needing detox that qualify for detox. We were asked about the cost of detox. It costs our organization $500 per bed per day to have a detox bed. That doesn't include the costs of our partnership with Alaska Native Medical Center. ANMC provides 24-hour physician's assistance coverage for us and medication. So those are additional costs. We were asked if we could add any beds. And at this point, our building is at capacity. We have 14 detox beds on the top unit of Ernie Turner Center. So we have 10 medical beds and 4 social beds. 9 of the medical beds are funded at about 80% by the state of Alaska. We leverage other funding to fund the rest of that. The 4 social beds cost approximately $350 a day per bed. And the state pays for about 80% of that, and we leverage funding for the rest of that. There seems to be some confusion about who we serve as well. We serve any population over 18 other than sex offenders and arsons. And the reason we exclude sex offenders or arsons is because of zoning issues. We're not allowed to admit that population. So I wanted to talk a little bit about our utilization rate. That has also come into question recently, where we were utilized at 3 years ago, we were always utilized at 100 or 110%. I know that doesn't make sense, but that extra bed isn't state funded, so we were overutilized. Our utilization has gone down over the last 3 years from approximately 600 admissions a year to 350 a year. And the reason this came to my mind is that you all were talking about a reduction in the need. Our reduction isn't because of the need, but some regulations that we've bumped into recently regarding nursing regulations. So the nursing regulations, a few years ago, it was brought to our attention that you had to have a registered nurse do the initial CWA, which is a withdrawal scale assessment, or the CALS, which is a drug assessment. So we had to go from LPNs, we were running all LPNs, which was much more cost effective with no issues on our unit. We had to move to have registered nurses do all of the admissions. So the reduction is, of course, trying to keep a registered nurse, trying to pay a registered nurse. If a registered nurse is on a detox unit, they have the ability to go work maybe on the peds unit or, the heart unit, they choose to go. So keeping nurses, paying nurses, hiring nurses is an issue. We're working with the nursing board on some innovative ways to kind of get past that. So we meet with them next month on the 8th to work on that. As far as hospitals providing detox, if you look at the cost of a hospital bed opposed to a detox bed, it's just, I'm not saying that the folks aren't worth the funding, but it's not cost effective to have folks detoxing with all the medical staff that run a hospital. It's more cost effective to do for nonprofit or private providers to provide that service. Let's see, what else we have? Got a lot of information if you have any questions.
Amanda, good question?
I thought it might just be valuable to share with the group the different kinds of detox that you do.
Sure. So we provide medical detox for all drugs and alcohol. So because of the population, detox usually is, from 3 to 7 days. Our population, because of the medical issues associated with the chronic inhibitorants and hard-to-reach populations, there's some higher medical needs. So sometimes we keep people from 7 to 14 days until they're stable enough to move into what we call social detox. So our social detox, there may be some opportunities here. Social detox, an individual moves into social detox and they receive an assessment and case management. Groups, we take the population to AA meetings, anything that we can do to try to provide that person with wraparound services and motivate them to change. When we say motivate them to change, we're really saying motivate them into a treatment bed or treatment somewhere. I feel like there's an opportunity there. We have a bottleneck there because the lack of case managers that help us, lack of funding, lack of people, however we want to look at it. We would have the ability to, I think, move people into detox more rapidly and out of detox more rapidly if we had, like you said, beds, treatment. You know that's an issue, but also case managers to help us move these folks through this continuum quicker. We leverage some funding and put a case manager in that position, and we're seeing some pretty interesting numbers. A reduction in treatment abortion rates. We're looking at our 6-month follow-ups to see if we're making an impact, in the long, at the other end. We're just starting to gather up data, but I'm hopeful. It's looking hopeful.
Ms. Gray-Jackson, do you have a question?
Thank you, Mr. Chairman, and thank you for your update. And I have to tell you, you're probably feeling my energy because you answered my question before I had an opportunity to ask it. Thank you, Mr. Chairman.
Any other questions? Seeing nobody else, I guess, it's clear that there's a need for more detox beds. I think anybody who's listened to all this testimony realizes that when these folks decide they want to detox or need to absolutely detox, there's got to be a place for them to go rapidly. You can't hold off on that. Since you're physically at your capacity, and actually, maybe you can help me try to understand that. The change in the nursing regulation caused you to have a decrease in the population you've seen. So how does that not free up capacity, or what part am I missing that
Sure.
sounds like there'd be more capacity still?
Sure. I don't think it was so much a change in the nursing regulation other than it was brought to light that we had all been doing it out of regulation for a while. So the reduction in admissions had been happening over the last 2 years. We're at full capacity now. So you will see the numbers increasing again. Does that answer your question?
Yeah, I think so.
What you were saying was sometimes if they didn't have adequate
if they didn't have enough RNs on, even though they'd have empty beds, but they couldn't take anyone in because they didn't have anyone to admit them. That's why
RN has to do.
utilization went down.
And what we're doing now is we're using, rather than running LPNs on the floor, we're running RNs. It's not cost effective, but, you know, we had some other empty positions. We were able to leverage funding. I don't know how long we'll be able to do that, but we're doing that today.
So I think moving that regulation back to allowing LPNs or others of similar training to do that would be beneficial and would allow you to operate more cost effectively.
So it would be beneficial to the population. I know that we spoke with Al about maybe having some other certification be allowed to do the assessments, state certification or something. We're completely open. We've also thought about telepsychiatry, having telepsychiatry services in the hospital, and I just think that there's some barriers to that too with state regulations, but we're working on that as well.
Other than the 2 beds that Allison has volunteered sort of for possible details.
Oh, don't tell my staff.
Where, I mean, if
Confidential.
If the municipality was interested in increasing detox availability, how would we go about doing it? Where would we put it? Is a whole new facility have to be created? As we've had facilities close over time, but is that what really is required? And anybody can answer that question.
I wanted to say the state, last year, we put out a letter of interest to fund detox beds, either in Anchorage and or Mat-Su. Nobody went for it. It's like too big of a risk, too big of a cost. There's so much liability, it almost seems like it's got to be either attached to a hospital or really in close proximity.
Or, yeah, there needs to be, I'm not going to say that, but if somebody had a facility, if we're talking about sustainability here, right, and Medicaid billing when all that comes around, if a person had a facility that passed the IMD regulations, I want to say that's, you're aware of that, then that would help an individual with sustainability. If we add it to any of the treatment providers now, and I don't see anyone jumping on that, which I completely understand, the billing is going to be a barrier. They're not going to be able to bill for it. As it is, we are not able to bill as well. So our detox service is of no cost to the participant, and nor has it ever been.
Allison,
Yeah, I was just going to say, I would imagine that's the problem, because you also have, a for-profit hospital in this community that doesn't operate at 100% capacity, like Charter North Star, it's called North Star, but, it's regulations that prevent them. And also, just to be aware, sometimes, some of these grant opportunities or letters of intent, they come out, and I swear I think I'm on every listserv, but we're really not. Unless you're funded by a state program, you don't receive notifications of what they're asking you to do. Like, we don't receive anything from DBH, and so therefore we're not included in that. So sometimes I think we just challenge ourselves to, I know to talk to these other organizations and say, be a partner, in the process. They're just not aware. It's not that they're not willing to. And I mean, I'm not speaking for them and never really had a conversation with them, but I know that they were approached by Campus Active Military, and they opened a 10-bed active military detox unit. And so maybe they're willing to open up, another conversation, because they actually have capacity. So just saying, throwing that out there.
And that's so everyone's aware, the 10-bed capacity that was opened up is for active military.
Right,
So
only.
it's actually part of your duties. So the general population will not be utilized.
But I'm just saying, if they were approached and they found a subpopulation that they found funding for, voila, they found 10 beds.
Yeah.
So I think sometimes if we look at what they may have, they may find the same kind of resources.
What will TRICARE fund?
TRICARE will cover all of those beds.
They'll cover all those beds.
The 10 beds.
Yeah, 10 beds.
And that is a definite incentive to open up a 10-bed detox
Right.
center.
Right.
The billing mechanism.
Right.
But we as providers with the IMD exclusion don't have that opportunity.
Quick question. Of your, the population that you generally see, or actually just say the 30 people that are actively looking currently for detox. Do you have any idea of what the average is of how many of those 30 people are what we sort of classify as sort of the chronic inebriate homeless, as opposed to other populations of folks who may not be homeless and just be alcoholic or substance abuse?
Sure. So I could get you some hard numbers on that, but I would say 30% homeless chronic inebriate. The rest of the population are a pretty young bunch that are going through lately heroin users, mid-30s and under.
And that's just the ones that report that they are homeless or have housing. I mean, it varies, but it's usually when they come in, they have no housing to go to. Which is where the case management comes into play too. That's really important.
And there's also incentive to reporting heroin, intravenous drug use, because it gets you placed into detox quicker.
Right.
So that's a factor as well on that data.
Any final comments, questions? Thank you. Appreciate the follow-up. It's all information. I see more obstacles now than I realized even beforehand, but it's important to understand what those obstacles are, and that was very helpful. Thank you. To the point in our agenda where we have member comments, so Ms. Gray-Jackson.
Thank you, Mr. Chairman. I just want to thank everybody for being here and tell you how much I appreciate the questions and the comments. And fair warning, before you go outside, it's 82. So, all right. Yeah, thank you.
Well, and I just want to thank you all for what you're doing to help the people that really need the help. It's got to be a difficult and sometimes thankless job, so I'm thanking you. And the fact that you reported that 30 people called today, that's just, we got a ladder to climb, and at least we've got some information. Now we just have to come up with a plan and then try to find some funding.
Yeah, the easy part. I too just want to thank folks for being here. I think one of the values of all of you that come to these meetings regularly is sort of the interaction that kind of develops between these different providers and organizations, that you do see some of those links being created, or at least making everybody aware of where the gaps are. It's certainly helpful to us to see those various pieces and to get the input from you. So you're not just here at the meetings, you're a very valuable participant, and I appreciate it. And now it's your turn. It's audience participation. If you have any comments, questions, or any other issues related to this topic, hopefully, this will be the time. Yes, ma'am.
I just wanted to add one thing too. DBH and the Mental Health Trust partnered on funding a coalition director position for the Anchorage Coalition to End Homeless for a 3-year timeline. And really part of the rationale in doing that was to help build capacity at the coalition level for local planning. And so I think that what they're doing right now with establishing a coordinated entry system in order to prioritize individuals for service based on vulnerability and need, which is essentially their use of public services as well. I think those efforts should be really supported by this entity, as well as their work around establishing a new local plan for ending homelessness. So I'm not sure how the crossover has been with that, but that's how we're trying to support the communication between providers through that coordinated entry system.
Amanda?
Folks aren't on the email list and would like to be on it, they can sign up as they walk out. And there's blueberry muffins that were dropped off by John back here if folks would like them on their way out.
Allison?
I would like to say to Amanda, I am on your email list, so I know that I get it. It's one of those things, is the balancing, all the different meetings to attend. But there are great examples in our community of people collaborating that sometimes we realize we're the best kept secrets of doing it. And I know each time I go even to Juneau or I go to the assembly and I talk about different partnerships, they talk about, well, if the nonprofit world would just ever work together. And I think maybe it's just not clear. One of the beauties of taking 7 years to raise the money to get into a new space is we got to really research what are the barriers for our kids succeeding. And as we looked at it, we realized substance abuse, number one, and mental health. We now have a full-time clinician from Anchorage Community Mental Health that's there seeing kids. We have a partner, substance abuse counselor from Volunteers of America that's seeing our kids. We have 9-Star there full-time in employment and education. So those things do exist. Sometimes we just don't tell people that we're not about trying. Covenant House is about finding the best of who does that service. South Central is on site. It's been a game changer for us with getting people access to different services. We're working with CITC. Providence has behavioral health. So there's a lot of things that I just want people to know that sometimes if we're not present at these is we just can't be present at everything, but please think of us, and if there's an opportunity that we can do something to stop this cycle, we're all about it.
Thanks, Allison. Duly noted. Seeing no other comments or questions, we are adjourned. Thank you.